So, coming to the last part of the talk, again, how to decipher dysfunctional lens index. This is a new term introduced few years back by one of the authors, and how to measure depth of focus on this, and how to use this depth of focus in planning various IOL and increasing the presbyopia range. And this was introduced by uh, the term DLI, dysfunctional lens syndrome. It is just in Western world just to include or decrease the threshold for doing cataract surgery. They have introduced this and divided into stage one, two, three. In stage one, the lens is still clear and colorless, but it is stiffer and it's not fully able to accommodate due to presbyopic change in the lens, and the aberration profile has changed as already highlighted. The spherical aberration of the lens changes from negative to positive side, and in stage 2, around 50, 60, 56th decade of life, it starts to turn its color into mild yellow. It becomes slightly hazy and affects the patient by making the night vision little difficult, and it is not as good as it should be. And stage 3 is definitely have a cataract, and when the visual acuity goes down beyond less than 2050, and a patient has a vision with or without glare, or which involves visual impairment, and it hinders the daily chores of the patient. So how the eye trace helps us in classifying these patients into different categories. So it's based on it's a new software. It's based on uh, uh, combined opacification in the system as well as higher order in the system, both corneal as well as lens, as I already highlighted. And index is based on higher order aberration, which are again purely optical, and contrast sensitivity, and of course the pupil size, which is very important. And higher numbers are towards normal. The scale is given from 0 to 10. 10 is perfect 10. Up to 5 or 6, you can still do without doing surgery. Like in this case, there's a dysfunction lens index where the score is around 4.76, and rest of the things are okay. This is from the internal aberrations or the opacification. So here one can convince a patient to, and you can show the patient. It's a very good tool. You can say, this is how you look. This is a vision simulation, how you look like, and if you want to look perfectly clear, then you have to do something about it. And this is another patient having 6.6. So here the vision is relatively good. So you can still wait. Otherwise, sometimes become difficult to explain to the patient, should I wait? Or if definitely patient have symptom, night driving complaint and all, you can go ahead. And this is another patient. So here score is 8.47, but here the angle alpha again is very high. So you have to be careful. As of now, everything is fine. It's not an indication for doing a cataract surgery. So it's a sort of DLI, uh, which is not significant. The score is more than 5. And this is another patient where the score is just 2.76. So it shows in red, green, and yellow, just like traffic lights. Red is go ahead, yellow is it's I mean you can just wait, or green is clear signal. You have to wait. So and but in this patient, this quality of vision was partly because of the asymmetric bow tie. Patient had little changes in the cornea also. You can see the asymmetric bow tie on axial map, and here you can see again the internal aberration are too high. You can see very high bars. I want again highlight. So there are enough paper in the literature which has correlated dysfunctional lens index with the Scheimpflug lens densitometry, and this is the paper which has given the score, and which says that 10 is a perfect score, and DLI has stronger correlation with best corrected distance visual acuity as compared to the LOX classification. So CDA is more important than the LOX 3 classification. And this is very important, the depth of focus. So this is about analysis of pseudo accommodation in aspheric or extended depth of focus IOL using ray tracing or barometry. This is the depth of focus of the two eye. You can use this tool to increase the depth of focus in two eyes so that the range of accommodation increases. As we all know, EDOF IOLs have a limited range of defocus, varying from zero point 0.5, 0.75 to the recent IOLs have 1.5 or maybe 2.25, the recent one. So we can combine a mini or a micro monovision in these cases so that you can avoid multifocal and the photic phenomenon, as well as increase to have a good distant, intermediate, and near vision. So this is various types of presbyopic are available. I mean, it's a pseudo accommodation. This is how we have evolved using various types of multifocal, trifocal, now EDOF, and now hybrid monofocal with EDOF IOLs. I won't go into details. So there are different types of presbyopia correcting IOLs, and these are the various types of based on different principle of EDOF. We have Minival, the Vivity, IHANS, Technis Synergy. Basically, there are four principal: pinhole effect, diffractive, and based on asphericity. These are the main principle on which these EDOF IOLs are based. But what the patient is concerned about is quality of vision. He shouldn't have any photic phenomenon. His defocus curve should be large, and there should be good contrast and good reading performance. And most of the time, he wants to be spectacle free. So these are the recent IOLs, EDOF IOLs with different range of extended depth of focus. With this around zero point 0.5, this one, this is 0, this is around zero point 0.5, but even aspheric IOL around zero point 0.5 diopter of pseudo accommodation or a defocus curve if we compare. So there's hardly any difference between two. This one has around 1.25 diopter of defocus, and this lens has around 1.25, around 1.5. So we can use a micro monovision in these cases to extend the uh, depth of focus, binocular depth of focus. So we don't use a monovision because we don't want to have a monocular suppression. So we usually go with the mini monovision or an offset of around one diopter between the two eye. How we do that? This machine helps us to do that. So this is the point spread function of different IOLs. As we go, the diffractive type of EDOF, they have a large point spread function, so they are not, the quality of vision is not that good, so as compared to the other type of ion which are non-diffractive. So expanding the spectrum of these IOLs, we can by mini monovision we can increase the distance, intermediate, and near vision in these eye. This is one such case. We have targeted emetropia in the dominant eye and a sort of myopia in the other eye, 0.75. So this is the individual depth of focus, 0.67 and around 0.75. But once we do it on eye trace, individual defocus curves combined together, we increase the depth of focus of both eyes to the range of 1.8 diopters. So patient will be able to see almost clearly up to uh, one intermediate distance. All right. So that's how, and you can decide the offset also. The offset should be that if in one eye it's emetropia, the curve of here it should fall somewhere with at the midpoint, because at 50% this thing, you don't have a suppression and the functional vision continues, the functional vision. So but we have seen that the subjective depth of focus is always far better than the this digital or the what the machine gives, because they have various clues, monocular clues, multifocality of the cornea, the pupillary diameter, all those things adds on and increase the depth of focus. So this is another case to show the same thing. In the other eye, we targeted 1.15 diopter, and we have increased the range of defocus to 2.1 diopter. This is with the IHANS. And subjective depth of focus is much more. The functional one is around 2 diopter. Here it is the digital one is this one, but the functional or the subjective one is more than where we get a 50% vision. It's much more. So with the A1 EMV, it's advocated to have a just I'll finish. It has a range of EDOF of 1.25 diopter, and this the lens devised by Australian. Our this what is his name? I'm forgetting the name. The famous. Uh, okay, okay, all right. So again, here we target an offset of one diopter, and the advantage of this lens is again this lens is aspheric neutral, and this lens even cover even if you target myopia of zero point 0.5 diopter in emetropic eye or distant dominant eye, this even then you get a 6 vision, because the depth of focus extends to the positive side also, so that you are utilizing that quality of the lens in increasing the depth of focus.
Sir, I think
So
the time for our session is
okay,
up. We have the
so
next people waiting.
so this is what I wanted to explain. So in this, you can get around almost 3 diopter of depth of focus with this lens, and this is the binocular depth of focus, which is much larger than even Vivity. So you have another IOL ICRL cert, which has almost 1.75 EDOF. So you can have almost 3.5 diopter in both the IOLs, and this is about the Vivity. Vivity also does the same thing. So another so basically we can use this machine to select the second lens, how much we want to increase the without sacrificing the binocular vision. We don't want a suppression of the eye in depth of focus. We want a binocular vision.